This podcast is recorded in the land of the Kaurna people here in Adelaide. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members and trainees live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti o Waitangi partners.
To welcome our first speaker today, in our hospital we talk about call in the smart doctors, which are our physicians. So we're very honoured to have Professor Laura Magee, who's a special guest speaker of the Norman Beischer Medical Research Foundation and has come from Canada and is a UK trained specialist. Thank you so much for coming.
Thank you. Thank you for the invitation to address you and for the kind invitation. It's a real honor. And I'm starting the day with colorful slides because I think this is a really hopeful topic. I have no relevant disclosures. So 80 to 90% of women have at least one pregnancy. On an average, women have two. And so using American data, Vesna Garovic was able to show that if you look at the incidence of the hypertensive disorders of pregnancy according to women as opposed to pregnancy, you have double the incidence, so about 15% of women as opposed to 7% of pregnancies. Now, the link between the hypertensive disorders and cardio-renal-metabolic disease is now supported by robust epidemiological evidence. So preeclampsia versus normotensive pregnancies associated with an increased risk of cardiovascular risk factors as well as cardiovascular disease. So, for example, a fourfold increased risk of hypertension, particularly in the 2 years postpartum, a doubling of the risk of type 2 diabetes and dyslipidemia, and at least a twofold increased risk of cardiovascular disease. And you'll see there right at 6 o'clock in the figure, a fourfold increased risk of cardiac disease. And the risk is higher if your hypertensive disorder of pregnancy is recurrent or if it's associated with preterm birth. So there's a dose response effect. So the question is, why are the hypertensive disorders of pregnancy associated with this excess risk? We know that women are different when we study them after birth, but were they different before or were they changed by the process? And so in support of the primary role for pre-existing factors is the fact that when the relationship between the hypertensive disorders of pregnancy and cardio-renal-metabolic disease has been adjusted for traditional cardiovascular risk factors, the association has been either eliminated or largely eliminated. Now, that's not true for all studies, and I will show you an example of a really rigorous one in a moment. But just carrying on with the support for shared underlying risk factors, we have prolonging the maternal exposure to preeclampsia through expectant management hasn't produced any consistent effect on cardio-renal-metabolic disease. If you add a history of preeclampsia or gestational hypertension to traditional cardiovascular risk calculators, it hasn't had a significant effect. And I will note we're talking about 10-year risk here. But certainly a group that worked on development of a bespoke model was not able to really have any extra effect other than for the 1.7% of women at very highest risk. And they're not the ones who we really need help with. So this is the study on a coronary CT angiography after the hypertensive disorders of pregnancy that did show that there was some effect that couldn't be accounted for by underlying risk factors. So just to enlarge the panel for you, so the group of results at the top is gestational hypertension, and at the bottom is preeclampsia. And then you see trios of effect odds ratios and 95% confidence intervals. And so the top of each of of those clusters of 3 is the crude effect, and then the bottom is adjusted for all the things that we think of when we think of cardiovascular disease, like hypertension, diabetes, dyslipidemia, et cetera. And you can see with very few examples that bottom 95% confidence interval still remains nicely to the right of the odds ratio of 1, which is the vertical line. And also again, in support of an affected preeclampsia itself, is the fact that an HTP history seems to be more important than a high genetic risk score. So from among over 200,000 women in the FinGen cohort, there were almost 8,900 who had a history of preeclampsia. And if you look at the cumulative risk of cardiovascular disease until age 60 years for the hypertensive disorders, shown in red, compared with normotensive controls, shown in blue, you see that the red stays above the blue across the age range. So the darker shading at the top of the blue and at the top of the red represents a high polygenic risk score. So having a hypertensive disorder of pregnancy trumps the polygenic risk. And then there are experimental data that support the role for direct damage from the hypertensive disorders of pregnancy. And so there's an SFLT1 mouse model for preeclampsia. I am no animal research expert, but it is really seductive that mice have a very short gestational period and a very short postpartum period. And you can have a complete control over their history and their risk factors. And so the bottom line is experiments in these mice have revealed that they are changed by their preeclampsia experience. And so, for example, in response to the injury, mice with prior preeclampsia show different responses. So smooth muscle mineralocorticoid receptor activation, as well as exaggerated vascular remodeling and increased response to future hypertensive stimuli like salt. Also the way their plaques, not so much the way their atherosclerotic plaques look, but the way they respond, for example, with T-cell infiltration, is also different. So these mice model also suggest that preeclampsia does have a direct effect. So we know that our future can influence the present. We've all seen the movie, and we know that cardio-renal-metabolic disease is the #1 killer of women, surpassing breast cancer easily. And so this makes pregnancy, as we all know now, an underutilized stress test for future health. So we need postnatal follow-up. That's the next step, isn't it? But will it work? And we have to acknowledge that there are some important challenges here. First, knowledge and awareness of women as well as us in terms of practitioners. The difficulty of individual behavior change, we all know this as human beings with empathy. The suboptimal patient engagement that we see following complicated pregnancy, and not just the hypertensive disorders, but also gestational diabetes, and then the high attrition from follow-up programs. Our priorities to promote health are very different from women in the weeks and months and few years after birth, when the focus is on the baby and parenting. There are barriers and facilitators faced by postpartum women that we share in our normal lives, as well as specific to their life stage. And also, we know that we need to focus on lifetime cardiovascular risk, but public health interventions are so often geared towards an assessment of 10-year risk. And we know that underestimates the risk in these women because it's so heavily driven by age. Nevertheless, action is required, so action we must consider. And I couldn't stand up and talk about this topic anywhere, and particularly here in Australia, without mentioning the critical work of the P4 follow-up study. Amanda and Mark and Greg asked us the question, like, would it be helpful to know what's normal for women of reproductive age? So those following hypertensive pregnancy versus those following normotensive pregnancy. And so in a prospective study of almost 400 women following preeclampsia and normotensive controls, they deeply phenotyped these women at 6 months postpartum in terms of blood pressure, BMI, echocardiography, and extensive blood work. And I just want to make a comment about blood pressure. So here we have blood pressure values measured in a number of different ways. I'll just focus your attention on a few that were at least 2 standard deviations above the normal for women following normotensive pregnancy. And so with manual assessment of blood pressure, that was very close to 120/80. And so if we use that as the normal, rather than the 140/90 that we would use in the general adult population, or if you're a stage 1 hypertension person, 130/80, you see here that the women following preeclampsia in the blue bar, but 20% of them have an abnormal blood pressure compared with those in the red bar. And that's the similar pattern when you look at 24-hour blood pressures. So if we look at the interventions, we have systems approaches and longer-term care approaches, so surveillance and action. We have lifestyle and behavioral interventions, and I'd like to make a few comments about breastfeeding and weight loss, and pharmacological therapies, and particularly some focused comments on early and good blood pressure control, and then vascular targeted and experimental therapies are obviously on the list, but at the bottom in terms of volume of information. So, we recognize that these women need to be followed up, and all societies recognize this. But it's not been established which approach is effective in decreasing, if any, is effective in decreasing cardiovascular risk. And many societies have put forth tools for this. So we have the My Health Beyond Pregnancy tool from the Preeclampsia Foundation, and we have the FIGO Passport, Pregnancy Passport, for example. And I do want to emphasize here that the hypertensive disorders of pregnancy are not the only thing that are highlighted, and that's true for the Preeclampsia Foundation as well. There's a recognition that gestational diabetes, obesity, preterm birth, fetal growth restrictions, stillbirth, that there are a whole host of pregnancy complications that increase cardio-renal-metabolic risk and warrant follow-up, and these tools emphasize this. Now, they're also, moving away from pen, paper, electronic records. There are apps that are appearing. So Anatina Staff in Norway has developed the MumCare app, which she's testing, and the idea here is a digital companion for registration of cardiovascular risk factor measurements. Education optional. You can just be notified if you want, and push reminders. And then there are others. There's the PrEP app in Sweden, and I'm sure that there are many others in development of which I'm unaware. So this active area of research. So what should our focus be when we think about these women? And I just want to go back in time to the InterHeart study, which confirmed that more than 90% of the risk of myocardial infarction as a flagship cardiovascular disease event is accounted for by 9 modifiable factors. And we all know these: diet, physical activity, smoking, alcohol, hypertension, diabetes, etc. And what I want to do, there are the risk factors there, is actually just make a few comments about which ones are most important in women versus men. And if we see here, we see that diabetes and hypertension are of greater, they're more powerful risk factors in women. So those are the top 95% confidence intervals versus men, the bottom result in that pair. And then also exercise is particularly useful in women. So is alcohol, but that one obviously is not something that we're going to go out and advertise. Now, breastfeeding for maternal benefits. So we know breastfeeding has well-established benefits for the child, but do we advertise the maternal benefits enough? We know there's a reduced risk of breast and ovarian cancer, but there's also a reduced risk of type 2 diabetes and cardiovascular disease more broadly, and that benefit of breastfeeding has a dose-response effect. So the longer the duration of breastfeeding, the greater the effect. And just to show some more details about that, this is in these 8 prospective studies, you can see here that regardless of whether it's cardiovascular disease, coronary heart disease, stroke, or and I'm trying to remember, I can't read what the bottom one is, it's too small. But you can see that there are significant decreases associated with breastfeeding. Now, you can also see that there's a lot of heterogeneity, right? So the trials are not consistent, but it is primarily the magnitude of the effect that is at issue here, not so much whether there is an effect at all. So I promised to say something about postpartum blood pressure control. This has been a really exciting development over the recent years. So in this study, Stewart looked at mediation of the link between the hypertensive disorders of pregnancy and cardiovascular disease by modifiable risk factors. So, looking at inter-heart factors. And what they were able to show was that the 64% of the population attributable fraction of cardiovascular disease could be accounted for by 4 factors. Chronic hypertension was the number 1, and then you have changes in BMI, the number 2. Now, the SNAP-HT trial made a big splash when it was published, because this was an unmasked, randomized, controlled trial, a pilot trial, to look at whether monitoring of blood pressure and self-down titration of antihypertensive therapy would be beneficial. This was in a nice environment, NICE meaning the National Institutes for Health and Care Excellence in the UK, that advocated maintaining blood pressure under 150/100. So it wasn't anything particularly tight at that time. And then there were 5 follow-up visits over 6 months. And what SNAP showed was that actually blood pressure was significantly lower at 6 weeks postpartum, and that this extended out to the 6-month mark for diastolic blood pressure. And this is after women had come off their antihypertensive therapy, to suggest that that good blood pressure control in the hours to days after birth could be beneficial. But we've all been horribly disappointed by small trials, haven't we? So Jamie Kitt followed these women out to about 3.5 years postpartum, and showed that actually the 24-hour diastolic blood pressure remained lower in women in the intervention group, shown in red, versus the control group, shown in black. And that was true when he adjusted for baseline blood pressure in SNAP-HT, as well as when he adjusted for subsequent salt intake. And then he went on to do the POP-HT trial of 112 women to self-monitoring with physician-optimized blood pressure management, and again showed that blood pressure was significantly lower in the intervention group than in the control group. And so systolic and diastolic shown there. He also did echocardiographic follow-up and showed that there were a number of structural benefits and functional benefits associated with the intervention, shown in these violin plots in blue compared with the control in pink. And here you have left ventricular global longitudinal strain, left ventricular mass was lower. You have changes in left atrial volumes that were more beneficial, and diastolic function to suggest that there's really something in this. And the SNAP2 trial is ongoing in the UK, and hopefully that will yield consistent benefits, and we'll have something that's that we can really action. And just a few more words about can we actually influence microvascular function after the hypertensive disorders of pregnancy? And the difficulty here is that almost all of the mechanistic information is either coming from drugs we use in pregnancy, so metformin, or from non-pregnant cardio-renal-metabolic populations. And there's just very little specifically ongoing in the postpartum period. So the strongest postpartum evidence, although most studies are small and observational, comes from lifestyle intervention, right? Which, you know, we all let out a big groan because it's just so hard for everyone. And then there are promising pharmacological candidates like statins. So there's an atorvastatin versus placebo after preeclampsia study that's ongoing. Metformin's being studied post-GDM. And then novel agents like semaglutide and other weight loss medications. But a primary difficulty here is that we don't have the safety information to administer most of these medications during breastfeeding. We know breastfeeding is important from a cardiovascular point of view, and we don't want to do anything to dissuade women. But how do we strike that balance between offering intervention and not stopping breastfeeding earlier, for example, and then how do we approach women so that we can get the information we need to actually use these medications early? And if the SNAP-HT, POP-HT program of work is it turns out to be replicated, then getting in there early as physiology is returning to its pre-pregnancy state is probably very important. So in summary, we have a well-established link between the hypertensive disorders of pregnancy and cardio-renal-metabolic disease, amongst other conditions. I just want to keep saying that it's even more important that this is an even more important issue when we consider women as a denominator and not pregnancies. So we can double it. That the most of the information for mechanisms for the link between the hypertensive disorders and cardiovascular disease suggests that shared underlying risk factors are most important, but there are data that suggest that there is direct damage. Now, of course, we're trying to prevent preeclampsia anyway for other reasons, but it suggests that that may also have an important effect on the cardiovascular, and that there are many potential avenues for investigation, but some general principles are that we need to do this as early in life as possible. We know that from pathological studies that teenagers and young adults can have atherosclerotic plaque, that cardiovascular disease represents the greatest cardiovascular risk in women, that there's little RCT data, and so we all need to get involved here and talk to women about trying to return to their pre-pregnancy weight, breastfeeding for their baby and for themselves, and having early excellent blood pressure control. So with that, I will end. And thank you very much for your kind attention this morning.